Dr. Juno Thomas, the head of the Center for Enteric Diseases at the National Institute of Communicable Diseases. Dr. Thomas, a very good evening to you. Thanks for joining us. Welcome.
Good evening. Thank you.
Overall, what's your analysis of how South Africa has dealt with coronavirus?
I think there have been very encouraging results following the lockdown. I think if you look overall, although we are experiencing cases every day, and unfortunately deaths as well, the trajectory of the growth in the number of cases has been fairly low compared to many other countries where they've seen a much more rapid growth in the number of cases. So in terms of what the government set out to do, and that was flatten the curve, so give us more time as a country to prepare our healthcare system infrastructure to deal with a sudden surge in the number of cases. I think it's been successful overall. But I don't think we are anywhere near the peak as yet. I think as lockdowns begin to ease, we need to really brace ourselves for a possible increase in cases and the resultant stress that it will have on the healthcare system.
Dr. Thomas, should we really look at how South Africa fares against the rest of the world, looking at the triple-digit increase that we've been seeing in the past few days? Because it is very alarming. In as much as we still are, we still have recorded the lowest death rates and the lowest infection rates compared to the rest of the world, but having such a huge jump in infection rates on a daily basis is really something that is concerning.
So I think what one needs to take into account is you test and then you find cases. And as our testing capacity has ramped up and the number of people in the community that are being screened and tested has increased dramatically, of course we are going to see an increase in the number of cases. So to date, almost 169,000 tests have been conducted in the country, and over the last 24 hours alone, there were almost 7,700 tests conducted. So it's not surprising that we are going to be picking up more and more cases as our testing increases. And it's projected that our testing capacity is going to increase even more drastically over the next month or so, particularly in the public sector. And as the mass screening program really gathers momentum across the country, we will still see an increase in cases, and that's because our targeted testing is going to improve and increase. I think part of the problem is we're in somewhat of a unique situation. We're an upper middle income country, but we have fortunately extremely good laboratory infrastructure and laboratory testing capacity, but we also have quite a high vulnerable population, and this is not necessarily just elderly people and those with underlying comorbidities, but we are also worried about people with HIV that perhaps aren't on ARVs or are not biologically suppressed that may also be at higher risk. So there haven't been other African countries that have been able to do the amounts of testing that we've done. And therefore, I think we are in a somewhat unique situation. We can't compare ourselves to Europe or the US, but we can't compare ourselves to other African countries either. So I think we'll just have to see how it plays out. But I don't think that we're going to see a decrease in the number of cases. And in fact, the more cases we detect, the better it is, because it means that we can trace those cases, make sure that contacts are quarantined or tested if they're symptomatic, and try and block the chains of transmission.
Dr. Thomas, let's talk about the testing and the screening protocols. Say, for instance, a patient or a person has the virus, and then upon screening, it is found that he is within the threshold, the normal threshold of what's called the normal temperatures, and is let go. Shouldn't testing and screening go concurrently?
So screening means answering a set of questions as to current symptoms, and the criteria for symptoms has changed, and at the moment it's an acute illness where you have one or more of a fever, cough, sore throat, or shortness of breath. So you don't necessarily have to have a fever. Even if you just present with a sore throat or with cough, for example, then you should be tested using the revised case definition. We know that from many case series in various countries around the world that not everybody gets fever. So that's why it is important to take notes of the other symptoms that have been commonly reported, and that is sore throat, cough, and shortness of breath. Some people may also experience diarrhea. Some people may also experience severe aches and pains and severe tiredness. But overall, the important symptoms to look out for are fever, shortness of breath, cough, or sore throat.
Evidence is now collected around the world that elderly people are the most vulnerable group. Now, this is contrary to assertions by medical experts, most of whom we've had on the show, that coronavirus or COVID-19 attacks all age groups. So what is the correct position here?
So I think there's a difference between who is likely to get infected with the coronavirus and who is likely to develop more severe disease and more likely to die. So what we do know is that all age groups can develop infection, and it depends on the degree of close contact you have with someone who's ill and perhaps the amount of virus that you're exposed to. And what we do know is that around at least 80% of people who do get infected with the virus will either have extremely mild disease or in some cases might not have any symptoms whatsoever. But then it's another 15% or so that develop more moderate to severe disease that might need admission to hospital for oxygen and supportive care, and then around 5% who develop critical disease such that they might need admission to an ICU for ventilation. And it's the elderly that are at extremely high risk for developing the severe and critical forms of disease that then are associated with the highest death rates. But it isn't just the elderly. It's important to note that other risk groups include people with underlying heart or lung disease, people with diabetes. In the US, it's been shown that people who are morbidly obese are also at increased risk for more severe disease and death. So there really is a broad spectrum of people who can get severe disease, but it has been in most countries the elderly that are prone to the more severe forms.
Should we rather read into the data that has been coming from the high-income countries with much more sophisticated healthcare systems in our assessment as to which group is the most vulnerable?
So that's a difficult question. As I said, we are in a unique situation in that we have the testing capacity and the laboratory infrastructure that we can conduct a large number of tests, but we also have a very different population than many first world or developed countries do. In that we have a different patient profile. So the proportion of our population that are over 65 is lower than that of many other developed or upper income countries. But then we also have a much greater proportion of the population that are immunocompromised from, for example, HIV. We also have a lot of people with TB, and we know that underlying lung disease is an important risk factor for severe disease. So unfortunately, we don't have another country that's in the same sort of situation where they've done a lot of testing and they have a patient, profile in their population that mirrors ours. So I think what is important is that many other countries in Africa are going to be looking to us for what we find in terms of who's more likely to develop severe disease, who's more likely to die, which are the patient groups that we really need to target for prevention and to protect them from becoming ill in the first place. So I think hopefully we're going to be able to share our experiences with other African countries that don't have the capacity to do as much testing as we do.
And having said that, Dr. Thomas, what is more important? Is it the capacity to deal with the pandemic with much more elaborate and stronger and perhaps sophisticated healthcare systems, or is it the capacity of raising awareness and with heightened containment measures at the local level? I mean, I suppose then that this conversation becomes synonymous to the chicken and egg issue.
Exactly. So I think we can, certainly having been a country that's, been one of the last to have imported cases and its own community transmission and local cases being reported, is that we've been able to monitor what's happened in the rest of the world, in other countries. And I think it's important to note that you need a mixture of both. You definitely need a prepared healthcare system infrastructure, because what we do know is that despite best efforts, there is still transmission of this virus, and you will still be getting people who fall ill, that need to be hospitalized, that need oxygen, that need critical care. But it is extremely important to focus on preventive measures to try and just keep the transmission as low as possible within the community, and that will slow down the rate of transmission and just make it much more likely that the healthcare system can actually cope with the increased load of patients.
Let's extend our analysis, if you can, Dr. Thomas, to the efficiency of the lockdown measures that have been put, in South Africa and perhaps in the rest of the world. In South Africa, in a country where a huge chunk of the population lives on a hand-to-mouth basis, who certainly cannot afford to stay home for the duration of the lockdown, and heaven knows how long that will last. And taking into consideration the fact that the president's stimulus plans are still yet to be rolled out. There's so much groundwork that needs to be done in order for the stimulus package or the stimulus plans to be implemented. And in the meantime, South Africans cannot wait for that. They still need to go out there and hustle for more food, to bring food on their table. So should we judge the success of the lockdowns in the highly developed countries and try to implement that model into the South African context?
I think, as you point out, the lockdown has had very serious deleterious effects to millions of South Africans who have suffered economically as a result. And I think the important thing to bear in mind that what the lockdown has done is it has slowed transmission down and allowed us a few weeks to make sure that we increase our healthcare system capacity as far as possible. So it allowed the plans to get field hospitals up and running, to get supervised quarantine and isolation sites up and running, to make sure that all the hospitals were stocked with PPE, to make sure that the laboratories were capacitated to rapidly increase number of tests, and also to put the mass screening and testing program in place. I think, we all knew that lockdown can't be infinite in our case. We need to restart the economy, and we need people to be able to earn a living and to feed themselves. But hopefully what this very stringent lockdown has done is it's bought us some time to be prepared. But that's what it is. We are preparing ourselves, and I think we must be under no illusion that the number of cases is not going to increase and that we aren't going to see further transmission or deaths. Unfortunately, that's a certainty, and it's just about being as prepared as possible.
And I suppose then that how long this lockdown will last is wholly dependent on people's attitudes. I mean, it is certainly a behavioral issue. And if people don't abide by these lockdown regulations, we're certainly going to go back to level 5, and which is really frustrating for everybody, socially speaking. And of course, it is a huge frustration on the country's economy. So do you get a sense then that people are really taking coronavirus seriously?
So I think, I have mixed feelings about that. I think on the one hand, I've been extremely impressed and encouraged at how South Africa has rallied together during the lockdown, and, people have supported each other. But, there are many instances where lockdown regulations weren't followed, and, there were major transgressions that led to, a lot of clusters of transmission. And it's extremely unfortunate. But I think, overall, the sense was that the rate of transmission was slowed in the populations where we were seeing most of the transmission. And that, unfortunately, was in the more affluent populations, because it was people that had traveled internationally, that then brought, infection back. And so it spread in those sort of socioeconomic groups first. But now that we have community transmission, I think it's extremely important that, all of the risky social behavior, for example, very large funerals or very large faith-based gatherings, where we know we've had incidents of outbreaks and clusters of transmissions within the country, that those need to be, particularly governed in terms of adherence to the regulations.
Now, realistically, when can we expect a vaccine for COVID-19? And is there any certainty that there will be a vaccine down the line? I mean, there's reports being thrown around that Australia already has the vaccine. On the other hand, there's Israel, which is reportedly does have the vaccine, and Cuba, some people say that Cuba does have the vaccine. I mean, is there really a vaccine? And the time limits, or rather the timelines have been, different timelines, I beg your pardon, have been bandied about that 12 months or 18 months is when we should be expecting a vaccine. So realistically speaking, when should we expect it?
So that's an extremely difficult question to answer, because it all depends on how successful the vaccine trials are. So they've only started vaccine trials in humans now. So they first have to assess the safety of the vaccine, whether it causes any side effects in the people that receive it, and then on the efficacy of the vaccine. In other words, does it really prevent you from being infected with coronavirus if you've received the vaccine? So that all may take some time. And then even when you have got a successful vaccine candidate, it's then having the mechanism in place to mass produce it at a global scale. Because, there will be billions of people that will be eligible for the vaccine. And, it's just about how practically does one make that volume of vaccine at very short notice for everyone around the world. And I think that's going to be very difficult. So I think we mustn't pin our hopes on having a safe, effective vaccine available for our population anytime soon. I think conservative estimates are looking at between 12 and 18 months at least. But I think over the next few months, we should get a better sense from all the vaccine trials that are being done on whether they are safe and possibly efficacious vaccines that are coming out of any of the trials.
Dr. Juno Thomas, the head of the Center for Enteric Diseases at the National Institute of Communicable Diseases, joining us via Skype. Thank you so much for your time. Much appreciated.